Prova.
In realtà non è registrato al momento perché poi noi cambiamo modalità. Allora. Dovremmo esserci. Lei può usare quello che vuole. Allora, c'è la telecamera, che è più o meno qua, più o meno qui. Se vuole può usare sia questo o quello, è uguale. In entrambi dovrebbe funzionare. Possiamo aspettare ancora 2 minuti.
Dalle 3:10 alle 4:10 cominciamo. E c'è una parte di domande prevista?
Sì.
No, Okay, I think mic works. And so we will talk today about atrial fibrillation and cerebral health. Why this topic? Because first of all, it's something I'm much involved in. And I'm a Matteo Anselmino. I'm an electrophysiologist, over than a cardiologist and associate professor in cardiology. And in my everyday practice, I perform procedures on patients in interventional electrophysiology. And the main business of a lab, a EP lab performing interventional electrophysiology, is in more or less over all the world, atrial fibrillation. So let's say roughly 50% of the patients presenting to an EP lab present for atrial fibrillation and undergo a treatment for atrial fibrillation. And over the years, there's emerging evidence, and hopefully I will try to convince you that it's a little bit more than just emerging evidence, that there's a deep link between this arrhythmia, atrial fibrillation, and the health of our minds, so the cognitive performance overall. These are my disclosures, and they relate more or less to the fact that I am consultant and I receive some grants from the companies that actually produce the catheters to perform these procedures. So I think it's relevant, and you should know this. I don't think I'm biased, but it's correct to know that it's there. As I said, for the EP lab, it's the main business, but why? Not because we search too much actively for atrial fibrillation, but because atrial fibrillation is really highly prevalent. And it's also increasing as incidence over the years. This is because the general population is getting older, and this is obviously a very good news. But on the other side, we will have more bystander pathologies. And two are very, very strongly there in looking at the epidemiological data. One is heart failure, and the second one is atrial fibrillation. And also these are actually quite linked together, but there would be another topic to discuss for hours. Going back to the arrhythmia, atrial fibrillation is increasing. It's very common above 65 years of age. And over the years, we will see more and more. If you want to be a little bit pessimistic, you can say that if you have in front of you an adult of about 55 years of age, he will have in his remaining lifetime 30% possibility to have atrial fibrillation. So if we have in front of us 3 adults over 55 years of age, you know that one of them is going to have atrial fibrillation. Why is it important to detect and to diagnose and eventually to treat? Because it does impact survival. In fact, this is known since more than 20 years. Men, women with atrial fibrillation die more than subjects with similar risk factors without atrial fibrillation. So in fact, it is relevant on survival. And why? There's several reasons, but let's say that the main reason, easily seen overall at the first glance, is that atrial fibrillation exposes to stroke. And it's not a normal kind of stroke. It's actually a very aggressive kind of stroke that relates to a higher mortality. So atrial fibrillation induces stroke at least 3 times more than patients without atrial fibrillation, subjects without atrial fibrillation, and this risk, of course, is increasing with age, and also the severity of a stroke increases with age. So these are very evident clinical data, and the first evident way to go on the treatment was in a, let's say, not mine, because I was early in my studies in that time, but of researchers, was to say, okay, so if atrial fibrillation relates to an increase of risk through stroke, let's take the arrhythmia away and we will solve this amount of excess of risk of death. And that, of course, was one of the, let's say, pilot, pivotal trials, initially pilot and then pivotal in the years 2000. And the most famous, there are several, but the most famous is this AFFIRM clinical trial, where they did the easiest thing ever. They treated a group of patients by rhythm control, and this means that they did everything to restore sinus rhythm instead of keeping the patient in atrial fibrillation, compared to a second group of patients, but they just adequately treated their heart rate. So if atrial fibrillation commonly achieves high heart rates, these patients were given medications and drugs to lower their heart rate. So the comparison between the two groups was treating the arrhythmia, so taking it away, against dealing with the arrhythmia, so putting the heart a little bit more at rest, but however, in the background, keeping the arrhythmia. And given what we said before, not everybody, but it was convincing to think that there would be a benefit in those in which arrhythmia was treated and the normal sinus rhythm was restored. But in fact, this was not what happened. So over more or less 3.5 years of follow-up, you can see here the famous Kaplan-Meier curves, where you can see that there was no statistical difference between those treating atrial fibrillation compared to those instead that had heart rate just checked on. So from there on, there was a clear recommendation to treat the patient, but not to improve survival. The patients were less sick, they had a higher quality of life, higher performance, physical performance, but they did not die less. So in fact, it was a treatment more or less symptomatic, not to improve survival. But as I said at the beginning, the problem, the reason why we want to detect atrial fibrillation is that people with atrial fibrillation die more. So we have to look into other mechanisms, pathophysiological mechanisms, that may explain both things, why we didn't see the benefit of treating the arrhythmia, and why and how we need to improve the survival of patients that have atrial fibrillation. I will not go into the details of this slide, but there's several mechanisms that may link atrial fibrillation to something abnormal. And something abnormal may be the fact that by beating irregularly, the cerebral perfusion of our brain may be affected. Plus, systemic effects of this irregular beating may cause inflammation, and not only anticoagulation status, procoagulation status treated by anticoagulants. So in fact, as I said, without going into too many details, there are several mechanisms that atrial fibrillation can affect the normal bodies and especially cerebral homeostasis. So back in 10 years later, when the AFFIRM came out, the first evidence was from the group of Torino, the previous boss in Torino in the cardiology department. It was Professor Gaeta, and he was coming from Asti, and he collected in that hospital a number of cerebral MRs from patients suffering atrial fibrillation and from controls. So subjects with the same risks of hypertension, dyslipidemia, and diabetes, and all the known cardiovascular risk factors. And he performed a cerebral MR in all these patients. And the cerebral MRs showed something very simple, but quite catchy, also for the general population. In fact, in those years, it came out also on non-medical reports, on the press. People with the risk factors without the arrhythmia had some lesions in their brains because they had other problems, and they had a mean number of 12 small lesions in their brain. People having paroxysmal atrial fibrillation on top of the risk factors had 28 lesions in their brains, and those having a persistent arrhythmia, so the persistent form of atrial fibrillation, had up to 40 lesions in their heads. Why am I calling these lesions? Because these patients are all patients not suffering a stroke, not even a TIA. So these are the so-called asymptomatic cerebral lesions. If it didn't undergo the MR, nobody would know. But we did, and we found. And the fact that they're stratified by sinus and the two forms of arrhythmia can't be just a chance. So the second step is to state that these are silent lesions in our brains. We really have to test if it's really silent. So what was done in these 3 groups was to undergo a cognitive test. It's called the R-bands. There's several cognitive tests. In this case, we used this test that actually investigates in a thorough manner the immediate memory properties of a subject, visual spatial abilities, language property, attention property, and delayed memory. It's a test for about 20-25 minutes, so it's quite stressful also for the patient. And what came out was not too surprising, but who had more small lesions in his head had a overall lower cognitive performance. So all the medical literature was calling these lesions silent cerebral lesions until this time point, because so silent they are not. Because in fact, if you search for a problem, you will find it. So there are cerebral lesions not giving a stroke, not giving TIAs, but lowering the overall performance of our brains. And if you want to choose if to have or not to have such lesions, I'm sure everybody will choose not to have them. So we should do something against it. A second step, much more elegant, with much more funding, with much more people, high-level researchers involved, but somehow saying a similar thing came out a couple of years later. A very nice study in Switzerland, it's called the Swiss AF study, and they involved much more patients, about 1,700, and all performed a cerebral MR. Not just the 3 small groups, but were performed in ASTI. And in this the biggest ever experience in Europe, it came out that everybody with atrial fibrillation, more or less, has one of those small lesions. So it was not just what we found. In fact, if you want to look at the clinical stroke, this is really a great minority of patients in atrial fibrillation. But 20% have small microbleeds. 50% have neurogliosis, so fibrotic tissue instead of having neurons. And 20 plus 15, so 35% have small lesions, cortical lesions, so small infarcts. So all these, if we are in the tip of the iceberg, will be recognized as a clinical stroke, and all the other is something that if you don't search for, you will never know. So absolutely confirmed. So why people with atrial fibrillation, the Swiss people were really well treated, everybody, nearly a high percentage on anticoagulant, so protected for the embolic risk, have these problems in their brains? There's several reasons, and what I did in the last 10 years was try to put together evidence to explain why atrial fibrillation may give this kind of problem. So you start, as always, with a model, and in my case it was a computational model. It's a collaboration with the Polytechnic of Torino. And actually we modeled more than 5,000 beats at different heart rates in models of cerebral perfusion and circulation, very fancy fluidodynamic sets of experiments. And what came out was quite clear, that both flow, and these are the lower lines, are all on flow. The Q stays for flow. And both for pressure, we found that it's really affected by the irregular rhythm of atrial fibrillation. You can see the red is more or less the tracking of what happens in atrial fibrillation compared to the blue in sinus rhythm in both rows. And the reference is mean 17 beats per minute, both in atrial fibrillation and both in sinus rhythm. And it appears quite clearly that in atrial fibrillation, phenomena that are really rare in sinus rhythm occur more and more commonly. So if in a normal Gaussian distribution, we have some rare events that are 5% extreme on one side and 5% rare on the left side, and these are hypoperfusion events or hypertension events, so upper 5% in the range of flow or pressure, or lower 5%. and this is by definition in sinus rhythm 5%, well, this 5% becomes much more common during atrial fibrillation. So the 5% of pressure above the range becomes 8.5, and even more significantly, the hypotensive events, always by definition 5%, in atrial fibrillation becomes more than 5 times more common. They become 27%. And what does this explain? It means that a patient perfectly anticoagulated in atrial fibrillation will have, instead of 5% of the time, 27% of the time, hyperperfusions. So his brain will receive less blood than expected. And in 8.5% of the cases, instead of 5%, he will receive an overflow. Go back to the Swiss AF. We had microbleeds and small infarcts. The overflow may explain breaking the membranes and giving some bleeding, and the hyperperfusion, of course, can explain small infarcts. And this is just more or less saying the same thing at the same way. Who cares? This is computational. This is on a computer. We're doctors. We're not software specialists and programmers. We want to see this on a patient. Why is it not so easy? As a cardiologist, as an interventional cardiologist, we love to place catheters everywhere, in every hole. The more far away you can reach, the better we are, happier, even more than at the beginning when we just looked at the aorta or just from the outside. We really love to go and see. It's not so easy to go in the brain at the distal level and measure pressure, as we do in the coronary arteries. Unfortunately, I would add. But how to cope with this? There are some ways, and actually the eye, the retina, is a very nicely exposed way to look at the cerebral circulation. Capillaroscopy can be a good way to check for systemic circulation. And what we used in a study. This is NIRS, near infrared spectroscopy. What is it? It's something that was unknown to me until 2015, and then after that I had to study and I got a little bit expert into this. And it's a way to measure the flow of the brain directly from the outside. It's an infrared method. You can put 2 small patches on the head of a patient, on the frontal bone here. It's 2 patches. And the patches will give a special frequency light. And this reaches a couple of centimeters below the patch. And it will measure the perfusion, how much blood is coming and going. There's obviously a bias for the vein blood of skin, and that depends on the room temperature, on whatever other reasons. So this adjusted form of NIRS is taking this away. So also here, not going into the details of a methodology, but we actually managed the way on documented tools to measure and to estimate the perfusion of the brain in our patients. And then what was the experiment we set it up? Well, we have one scenario where we have a patient in sinus rhythm and in atrial fibrillation at a very small time distance. And this is electrical cardioversion. And electrical cardioversion is even a better experiment setting because we put our patient to sleep before giving shock. So he's sedated, not connected to stress, to reality, to whatever happens. And he has, just before the cardioversion, atrial fibrillation, just after the cardioversion, sinus rhythm. So let's measure the pressure, the perfusion of the brain of a patient just before and just after. And this is what we did. And we did this on more or less 50 patients to see what happened. I will not go into the details of which outcome of a measure we used, but it's this THI, it's tissue hemoglobin index. They're all proxies of a perfusion of a brain. and it's not relevant to what we want to discuss if to use one or another. But in 2019, on 50 patients, we measured before and after an electrocardioversion. And we wanted to see, of course, a change, and the change was quite evident. Monitoring was easy, multi-channel equipment. Obviously, we also checked on the pressure of the patients with a non-invasive monitor. We looked at saturation. We looked at multiparametric monitoring, not only the cerebral perfusion, to see if something in addition happened. But of course, our main aim was to check on cerebral perfusion. This is just an example of what happened of one of these signals that we may measure, so the tissue hemoglobin index. And this was chosen because in literature for other things, it has been shown as the most stable way to measure. But also other parameters gave more or less the same indication. And you can see that once we restore the sinus rhythm, on the right hand here, the tracking, the recording is very stable, differently from atrial fibrillation situation, where you see those especially the hypotensive events that are, as you remember from the modeling, expected to be at least 5 times more common compared to the normality. The good design of a study is that the patient is the control of his own. So you cannot say that there's other factors that may be differently distributed in the population, like hypertension and so on, so on, so on. Because every patient is the control of his own. And then, of course, you average the differences in the whole population to describe an overall effect, not on a specific patient, but on the population. And it was absolutely confirmed what we found at the computational model. Overall, 96% of the patients were successfully treated by electrical cardioversion. Obviously, cardioversion had to be successful at least for the following hour. Then the patient could relapse and the arrhythmia could recur, but we needed to measure a stable frame of time after the cardioversion in sinus rhythm. And the indexes, especially the coefficient of variation, significantly were reduced. These are the numbers before and after, and in fact, the cardioversion was giving stability. So how can we interpret this data? The fact that the Willis circle is trying to keep a stable pressure is absolutely true and well functioning if we have a regular rhythm. But if a rhythm starts to be irregular, it's like the pressure and the flow are not in parallel anymore, but they become, let's say, unparallelly mixing each other and going against the fact that the pressure is trying to be increased. So as soon as the autoregulation copes with a hypertensive event, it's really easy that the following 5 to 7 beats are hypertensive. And opposite, after 5 to 7 beats with hypertension, then the hypotensive response is over hypotensive. Because this irregularity, and the irregularity is the stamp of atrial fibrillation. It's its characteristic, the peculiarity. So overall, if you think about it in this way, it's not even too surprising. So the pressure perturbations actually accumulate, and the more we go deep in the cerebral perfusion, the more it becomes serious and severe. So in fact, the very end, the distal cerebral fibrillation, is the one, not the Willis circle, those lenticular straight arteries and so on that are deep in the brain are those suffering more. And we moved this to a further level. And the further level is that not all patients have the same cerebral circulation. And there are Willis circles that work better, probably, than others, because not all patients with atrial fibrillation have problems. There's few, but there are also patients that do not have problems based on this kind of fluidodynamics related to atrial fibrillation. So we performed, this is currently under consideration on a journal, and what we have done here is we performed a 7 Tesla cerebral MR in more or less 10 patients. These data come from the Netherlands. And then we studied the anatomy, the specific anatomy of these patients, especially of the arteries in the deep subcortical area of the brain. And we performed real-time, real 3D related fluidodynamics on the vessels of these patients. So the vessels involved were about 25, coming from 10 patients. And without going too much in the details, you see that some, like the lenticulostrate arteries, origin nearly 90 degrees from the anterior or medium cerebral artery. And what is emerging is that these arteries that origins in such a peculiar manner, because 90 degrees is really steep angle, actually they have very high shear stress. So if there is an irregularity in dynamics, it will be very easy that these colored spots, and these are actually only the origin, and then the bifurcations or angulations of these vessels, are spots of pro-atherogenic mechanisms with a classical way and pathway. So it appears that atrial fibrillation directly affects cerebral circulation by affecting these peculiarly originating vessels called lenticulostrate arteries. And these are those that give at least, not strokes, not the typical TIA, but that 20 plus 15, so 50%, 45% deep cortical lesions that we have called until now silent cerebral ischemias. If you're interested into this, there's a nice review that our group wrote on the last year, and in this review we have put together all links not only to the brain, but atrial fibrillation may actually give origin to, because the problem is not only on the brain. We have similar problems also on the coronary arteries. We have similar problems on the kidney. We have similar problems on the systemic circulation. But the brain is more sensible due to these peculiar anatomical findings. Not only our group has worked on this, there's also a Icelandic group. They have shown very nice study. This is one of them that actually went to measure the blood flow, not with veneers, but with a special kind of MR. It's a functional MR. And they actually managed to measure the volume of a brain. And also for them, it came out that compared to patients and subjects without atrial fibrillation, those with paroxysmal, or even worse, the cases with persistent atrial fibrillation, have a lower blood perfusion of the brain. So actually, they showed very similar evidence. So we're putting things together. But we are clinicians. We will go to the lab every day and we perform ablations and procedures, and 50% of our procedures are on patients with atrial fibrillation. So let's go back. Let's be practical and go back to our patients coming to the lab. It's nearly impossible that, although the AFFIRM study did not prove, how can this so evident sign of suffering of the brain did not come out somehow? Because if it's like this, it's quite odd that we did not measure this from a clinical point of view, not as researchers, but in treating our patients every day. So let's have a look in the last 10 minutes on what was there that we could interpret differently, more or less, from what was done until now. Well, there were some signs, And obviously, since we had this hint, then more and more evidence is coming out. This is one of them. And in fact, it's a big study on more or less 55,000 patients. And 16,000 were treated by rhythm control. So this means trying to take away the atrial fibrillation arrhythmia. And 40,000 were treated just with handling the heart rate. And you can see that the stroke incidence, despite the clinical risk, was always slightly higher for those on rate control. And obviously there was, and this is a major standpoint, there was a similar antithrombotic treatment. So all these patients received anticoagulants. So this surely was somehow a relevant statistical indication that was not read in the correct manner. Overall, there was a 20% reduction of strokes despite having anticoagulant in those patients trying to get rid of the arrhythmia compared to those just under heart rate control. And a very nice neurological study confirmed more or less this. This was done for other reasons, but these neurologists actually followed a big group of patients, about 5,000, for a 7-year time frame, so for a fairly long period. And these patients started more or less overall in the population about 67 years old, and then reached, obviously, in the 7-year follow-up, higher ages. And the median age overall was more or less 74. Every year they performed a cognitive test. And by testing, they actually saw in the first year a slight improve in the cognitive performance, but this was just because the subjects were remembering how they completed the test the year before. And then after year 70, this memory tended to fall, and they had a physiological decrease of the overall cognitive function. And this was more or less considered a healthy aging of a group. But within 5,000 subjects, as we said at the beginning, atrial fibrillation is very common, and as expected, more or less 10% developed atrial fibrillation. And by developing atrial fibrillation and going on performing every year their cognitive performance tests, they actually saw in this subgroup of patients a fast increase in the reduction of cognitive performance. In fact, what they speculated was that if you had atrial fibrillation, it was like you were aging 5 years more than those without atrial fibrillation. And this is a very strong indication, not even coming from the cardiology society and background, but from neurologists. But for sure are greater than us in measuring the cognitive performance outcomes. So another evidence that was not seen at the start, but had to be seen by putting things together, was that dementia seems to be increased overall with increasing age, and seems to be increased in patients with atrial fibrillation. So perhaps those small cortical lesions give stroke, and small subcortical lesions may explicit from a neurological point of view differently. So not with problems with speaking, understanding, or moving, but with cognitive performance. And in fact, both Alzheimer, and this is a recent thing we are studying, and dementia seem to relate. This is a meta-analysis putting together all the widest data on this aspect, and what clearly emerged is that despite not having a stroke or a TIA, atrial fibrillation increases the risk of having dementia up to 30%. So this is really a lot. I will answer after 2 different points. We're nearly finished. So why did the AFFIRM go wrong? What happened in this big trial? Well, it was one of the first big clinical trials. It's not that it went wrong. We have to see why the patients actually did not give this clinical indication. And it's quite easy to understand why we did not read this at the first glance. Because if we look at, remember, the affirm was small groups, 2 arms, getting rid of the atrial fibrillation, so rhythm control, or handling heart rate, so rate control. And it came out that it was similar between the 2 groups. Why was it not beneficial at the end in this big trial? Well, first of all, if we look at the things differently, the sign was there. Because if we look at the effect of having sinus rhythm, in fact, who had sinus rhythm had a 47% reduction of the endpoint of a study. Because the randomization was on trying to get avoid of a atrial fibrillation, not getting rid of atrial fibrillation. It was going towards treatment that were trying to get rid of atrial fibrillation. And in the year 2000, the only strategy were rhythm control drugs, so antiarrhythmic drugs. And as you know, antiarrhythmic drugs have several side effects and especially do not work 100%. They work about 30-40%. So if you checked at not those patients receiving the treatment, that those patients that were in sinus rhythm, the endpoint was absolutely strongly reached. And on the other side, if you check what happened of those patients that were receiving antiarrhythmic drug, they died 50% more. So actually the problem was not giving the indication to restore sinus rhythm, but the manner that you tried to pursue this, because antiarrhythmic drugs were and are still not a very good option. So more recently, 20 years after the AFFIRM, finally a clinical trial, even bigger, the East AFNet 4 trial, has shown that if you compare heart rate management with rhythm control, at least the only thing you have to report is that you have to be in the first 12 months of your arrhythmia, so you should not wait too much, because if you wait too much, then the benefits will get lower. But this trial, 3 years ago, has finally closed the discussion, saying that if you treat patients with atrial fibrillation under 12 months with a rhythm management strategy, it is beneficial in terms of strong cardiovascular endpoints: stroke, hospitalization, heart failure, and death. So changing the final outcome of the AFFIRM trial, putting all things together. What is still missing? The fact that restoring sinus rhythm will reduce Alzheimer, dementia, and improve the cognitive performance. And that is still not there. We have some signals. This is a meta-analysis on the big data that are still there, but they're more or less observational. They're still not randomized. And based on these, with a bias that they are observational, despite a wide population, because it's more than 40,000 patients, there surely is the sign that performing an ablation, so the most effective way to restore sinus rhythm, actually reduces dementia rates over follow-up, but is even quite short. It's emerging that over more or less 4-year follow-up, with one ablation, you save, with 41 ablations, you save 1 clinical diagnosis of dementia. And clinical diagnosis of dementia is not decreased cognitive performance. It's a very decreased cognitive performance, so low that your family members force you to go and seek help and receive a diagnosis. So this is a real underestimation of what is happening in our brains. But despite this, still there is the sign that there's a way to reduce dementia. So to conclude, I hope I convinced you that, well, first of all, you will face atrial fibrillation, because this will happen. Anticoagulation and heart rate management are standpoints, so this is what you have to start with. But the more your patient is young, you should not wait too much and act on the arrhythmia, not only thanks to the East AF-net4 to reduce cardiovascular outcomes, but finally we can say, so not only for symptoms, but also for survival, but we should really do the best to keep the sinus rhythm, to keep a healthy perfusion of our brain, and to avoid evolution towards dementia and keep a high cognitive performance. Still, we cannot state this to our patient. We cannot say that he has to restore to have a decrease in dementia, but I hope that in the following years we can state this. To date, we can say that we can do it for his symptoms and to reduce his cardiovascular events. And this has really changed over 10, 15 years. The reason why I think this topic is also good for this kind of meetings is to show that even if you start in a, let's say, late stage of a discover of a physiopathological mechanism of a pathology or a link between diseases, you can still affect treatment and indications in a relevant manner. So there's a lot of space for improvement in therapy and in management. So I consider myself relatively young, and I think that still, when I started, I had some seniors, some mentors that were giving everything for, closed and not to even discuss anymore. But there's in every topic space for these somehow little but relevant changes for our patients. So what I would also like to share with you is the fact that there's thousands and really wide space for your actions and to get a little bit involved in research and to, if you like a topic, just go deep into it and try to critically see what's there, propose, and try to change for the future. Thank you. I'll be happy to receive questions.
So, first of all, I would like to say that it's really a nice way to see, like, for example, the circle of Willis as a sort of mix of springs and not just pipes, which, again, suggests how important is actually the rhythm and how it plays in the balance and the spring relaxation and not, and how it affects the brain. And my question is, we are speaking especially about atrial fibrillation, but are there, for example, other types of arrhythmia that are correlated with this sort of problems? I mean, obviously, atrial fibrillation is the most common, and so it's the easier to demonstrate, but are there other pathologies?
Yeah. So within supraventricular arrhythmias, atrial fibrillation is the most common, but atrial fibrillation has a cousin, which is the cousin of atrial fibrillation. Atrial flutter. And that's also quite common. Little less, but it's common. One of the main problems is that they are widely, I mean, if you're seen from by an electrophysiologist, no, but whoever is not an electrophysiologist, they're nearly treated similarly. So a lot of databases and medical literature flag AF or atrial flutter as a very similar manner, and it's really difficult. From a theoretical standpoint, they should not act similarly in respect of the irregularity of the rhythm. So in the hypothesis that the spring and the overuse of the autoregulation system are, if they were true. So in fact, we tested this, and the starting hypothesis was that atrial flutter would affect less the cerebral circulation compared to atrial fibrillation. And in our group of 54 patients in the experiment with NIRS, we had 15 that had atrial flutter. And in fact, in this subgroup, there were no differences between pre and post electrical cardioversion. So it seems to be in that direction. But this I can say because they were my patients, and I know exactly who had flutter and who has atrial fibrillation. We tried this in meta-analysis, but the data quality is too poor. It's too common to flag the two things together. We wrote some editorials. One was recent, I think 6 months ago, on the fact that it's really dangerous somehow to consider them similarly. I believe that flutter has a lower risk of dementia for sure, and to reduce cognitive performance. And we have indirect evidence from this, that if you, in some cases, atrial fibrillation has a too high ventricular rate. And you can give whatever drug you want. You can try ablations and arrhythmia recurrence. And there's only way to manage the heart rate is to ablate the AV node and pace the heart. And pacing is as regular as possible. And there's evidence that cerebral perfusion in those with atrial fibrillation but a paced ventricular rate is similar to those without atrial fibrillation. Instead, those with atrial fibrillation with a regular rate have decrease in perfusion. So the problem, I started saying that the problem is not only atrial fibrillation, it's the irregularity. So you have to take atrial fibrillation. Careful to what I say, but I say that you could even leave atrial fibrillation, but get your ventricles to beat regularly. And this would be the same, and there's evidence for this. So flutter, that beats quicker but regular, with this basis, regular, on this basis, should not give a similar problem as atrial fibrillation. And the pacing example is it. But the data out there is too poor to analyze as I did for atrial fibrillation, as we did for atrial fibrillation. So I cannot answer. This is my belief. Yeah, sorry, he was asking already.
Yeah, I have.
You will get the microphone.
There's someone else.
Yeah.
Okay.
But then you can pass that. Go ahead.
I have a couple of questions. One is, does a rhythm control therapy after having atrial fibrillation for some years, I assume you may have some lesions in your brain. Does it in any way reverse the damage that has already been done?
This is an interesting question. So the chronic lesions in our brains will not reverse because they're not an acute sign of suffering. It's just a everyday basis. But what we also investigated, to be fair to our patients, is that the best treatment to restore atrial fibrillation, to restore sinus rhythm, should not expose the patient to the same risk. What do I mean? That when I perform an atrial fibrillation ablation, I go in the left atrium of my patient. And I perform little lesions in the left atrium to isolate the pulmonary veins from the left atrium. And what had been shown is that during the procedure, I may create some lesions that are very similar to those silent cerebral lesions that the patients with atrial fibrillation have on a chronic basis. So what you have to be sure about is that your acute procedure will not create something worse than what the patient will have if he doesn't do anything. So what was carefully studied was that some methods for ablation actually did create these lesions. First problem. The second point is that are these lesions similar at the MR, but do they progress similarly? Or so they stay? So this is the answer to your question. Or do they revert? So in case these small lesions are created by the ablation, there was a series in Europe, at least 4 or 5 series, they tend to revert over time. They more or less disappear completely over 6 months if at the starting point they're less than 2 millimeters. So if they're small, very rare, because it's a different pathogenesis. It's an acute little damage, maybe it's also some air embolism, a small material, even though on the MR they look very, very similar. So at the beginning we were saying, okay, let's not create more damage than what we're trying to save our patients from. And so this was a big discussion between, let's say, 2013 and 16. But those due to arrhythmia do not revert.
My other question was, as a general practitioner or a non-cardiologist, how should a doctor approach a diagnosis of atrial fibrillation?
Well, the first thing is make the diagnosis. And that's not easy, especially now with smartwatches, wearables. Patients will come to you, sometimes even having the diagnosis before you have even a suspicion of. So the patient is overtaking on the diagnosis of a physician. So the problem is when a patient comes to you and says, my smartwatch says I'm in atrial fibrillation, because anticoagulants and rate management are standpoints in patients with a normal diagnosed atrial fibrillation. These that come with a wearable are the so-called silent atrial fibrillations, or somehow asymptomatic atrial fibrillations, and there's no evidence that giving an anticoagulant to that kind of subject, not even calling him a patient, is not a damage, because anticoagulants do save from thromboembolic strokes, but unfortunately do have an hemorrhagic risk. So this is a problem. From a classical point of view, with a classical diagnosis of atrial fibrillation, you have to, for a general practitioner, let's say, you always have to go and to calculate very easily with a CHA2DS2-VASc score the risk of thromboembolism of our patient. If it's above 1, you can consider. If it's above 2, it's mandatory to start an anticoagulant. If a patient has symptoms, you should give something to lower his heart rate, typically beta blockers or calcium antagonists. If he's not symptomatic, you could also do nothing else, just anticoagulant. Then, as I said before, if you believe that there's an impact on something not commonly measured, so cognitive performance, you should also do something to revert the rhythm. But you can also direct him to a neuropsychologist to test it if you have a doubt. What I do personally, I do something, let's say, hybrid compared to these, because I don't think it's ethically correct to say that it's mandatory to restore sinus rhythm for your cognitive performance. Not yet. Perhaps it will be, but not now. What I usually do is I cardiovert my patient. At that point, he will tell me if he felt the difference by being in sinus compared to the days before he was in atrial fibrillation. And I have patients, young patients, that come back to me saying, I thought I was healthy, but I didn't feel the difference. But actually, now that I'm in sinus again, I have more memory. I managed to concentrate better. I have some students that say I was not able to study anymore. I was distracted. I have some very healthy friends in sports, agonists in sports, and that they say that had no problem in performing and in competing in atrial fibrillation. But then when they go back to sinus rhythm, they see the difference. Because, you know, our body gets used to the situation. And then it's very difficult to measure. So what I do is I cardiovert at least once, and I ask the person, if they feel exactly the same, then they can also stay in atrial fibrillation. But you have to give sensibility to this choice, let's say. There was, before, was asking for a while, since a while.
Okay, Professor, first of all, I just want to say thank you for your explanation. Thank you for this topic. As always, it's pretty interesting and you explain it really good. I have two concerns. First of all, we spoke before that atrial fibrillation is very common because any disease that can cause the atria, it will lead to fibrillation. Endocarditis, increase in the pressure. But what is the etiology of it? Because when we spoke about supraventricular tachycardia, we spoke about 3 problems, which are increased triggered activity, increased automaticity, and the cycle, the re-entry cycle. So which one actually exactly is the one responsible for etiology of atrial fibrillation?
So atrial fibrillation is very common because everything that increases the pressure in the left atria starts the arrhythmia. Why? Because embryologically, the pulmonary veins are eaten up by the left atrium. It's not the veins that go towards the heart, it's the heart that goes towards the vein. And commonly there's 4 pulmonary veins, right? This is also something that it's written everywhere, but in 2010 we performed imaging on these patients, and this common pulmonary vein branching is there in 30% of the cases. So 70% do not have 4, but we can stick with that. It's fine. But the point is that since the heart is going towards the vein, there's not a clear boundary between heart, left atrium, and vein. There are some myocytes that go towards the vein. And in some special parts of the pulmonary veins, there's nearly like just a couple of myocytes that are reaching into the vein to connect the vein to the left atrium. If you take any myocyte from a heart and you stretch it, this will give a depolarization. It's normal physiology. If you take a muscle and you stretch it to preserve his own structure, at a certain amount of stretch, he will give a depolarization. So at this portion between the left atrium and the veins, where these single myocytes reach to the vein, the pressure in the atria will stretch the antrum of a vein, and these myocytes will react as any myocyte will react, will give depolarization. The depolarization will fire on the left atrium. This will happen once and nothing happens. Happens 2 times, nothing happens. If it happens 1,000 times a day, you will end up in atrial fibrillation. So within the mechanisms, it's in between increased automaticity, because the stretch is considered spontaneous automaticity, and re-entry, because once the arrhythmia becomes persistent, it's because the stretching has remodeled electrically the left atrium, and there will be some areas with different refractory period. So it's going to be a functional re-entry. Some areas have shorter and some areas have longer refractory period. Some areas will have a long conduction and some will have a short conduction. And so you have small re-entry circuits. So atrial fibrillation is due to microfunctional re-entries and increased automaticity from the pulmonary veins.
Okay, and my second question is basically we spoke about the 1-year therapy and how it can help for the ischemia, but if I remember correctly, we spoke that atrial fibrillation, for a long time it goes for remodeling. Yeah. So as early as we can do ablation or as early as we can do, which will be better. But we didn't speak about those drugs. What, in the other hand, like those drugs will help the rhythm, will help everything so that the brain gets diffused. But about the remodeling of the heart, what we will do about it?
No, the normal approach is as soon as you have a diagnosis, you should start with the drugs, because you shouldn't lose time to plan a procedure, to see a doctor, the right doctor, to get into waiting list, to get to the hospital and go to the procedure. Will take, if you're really lucky, a month. If you're normal, 3 months. If it's normal and lucky, it's 6 months or even more. So you shouldn't lose time, because remodeling is there. After 7 days, you already have different proteins in your myocytes. So it's really quick, the remodeling. You should start a drug while the patient is, let's say, in waiting list for a procedure. Then once you call the patient and say you're ready to have him in the hospital for the procedure, if he tells you that he remains in sinus rhythm, you're gonna delay the procedure. But at least you didn't lose time. There's thousands of things I didn't show you, but there's clear evidence that if you treat arrhythmia in the first month, the final output at 5 years is much, much better than if you wait 12 months. And from 1 to 12, of course, it's exponentially increasing. You're welcome.
It's a follow-up on the previous questions, especially when you mentioned that some people that you treat their silent atrial fibrillation with the cardioversion, they self-report that they got better at certain activities or something. First of all, how much do you estimate that this improvement might be actually a placebo effect? And even if it is a placebo effect, does it affect your judgment on the issue or not?
I have no answer. But consider one thing. I asked the patient if he has symptoms. And those that say yes, I consider they have to restore sinus. Those that I recommend the cardioversion are those that answered no. So I ask, you have atrial fibrillation. And you come to me and you say, I'm perfectly fit. I have no problems. I went for a knee surgery because I fell or I was playing soccer. I had a problem. And once I got to the knee surgeon, we found atrial fibrillation. What should I do now? I'll keep it because I'm fine. I was playing, I had a knee problem. What's the deal? And I'll tell you, I don't think you're fine. You already are going to be nervous about this because you think you're right on yourself. I mean, why do you cardiologists think you know my symptoms better by myself? Okay? And then I convince you, I really struggle to convince you to believe me just a little bit to go for a cardioversion. Then, after cardioversion, if you say that you actually had a symptom, do you think it's biased or not? It would be biased in the other direction. You would kill yourself instead of telling me that I was right, because you were saying that you had no symptoms. So what you say is absolutely correct. I have no answer, no data to say. Placebo, nocebo effect is in there everywhere. But from my reasoning, I would see it in the opposite direction. And I made this example to make it clear to you. Do you agree or not? Would you tell me that you have symptoms if before you believed you didn't and I force you to a cardioversion? If after you tell me that you have, in fact you had, this is what I believe, but you're absolutely correct. There is surely some placebo in there.
This maybe reaches the debate of overdiagnosis.
There's thousands of nuance, but yes. Okay. Oh, sorry. Yeah, coronary artery disease, especially.
Better? Oh, yes.
I don't.
So maybe I repeat for the ones online. So I was wondering if there are also effects of the atrial fibrillation on the perfusion of other organs whose vascularization is characterized by autoregulation, such as the kidney or the heart itself.
Yeah, absolutely. If you're interested, you should read this review because there's a systemic narrative methodological review for each organ. So you will find also literature from lots of other groups, especially on coronary artery disease. Some bullets are here. I mean, the atrial fibrillation compared to sinus rhythm, you have an increase in pulmonary vein pressure. This means that the liver, the kidney, and the gastrointestinal have a congestion. So they have a more post-load. So they have a surely not normal hemodynamic. And the systemic arterial pressure, so in the aorta, the pressure will be lower. So the kidney will receive less flow. And due to the regularity of a rhythm, also atherogenic processes in the big vessels like aorta and kidney artery and the mesenteric arteries are affected. But there's lots of details on this. Our group mainly focused within the systemic and the coronary artery disease. And there's very relevant data that show that patients with atrial fibrillation and known coronary arteries have a poor prognosis compared to those with similar coronary artery disease but without atrial fibrillation. And this is due to microvascularization. So it's like the so-called Prince-Metal angina. So the circulation in the coronary arteries is surely affected by atrial fibrillation. And there it's much easier. I was saying from the brain, we can't go in with catheters, but they are tests with adenosine, just with a pressure wire. There's a way to go directly in the coronary artery and measure in the same patient the flow in sinus and in atrial fibrillation. And it's confirmed that in atrial fibrillation, the flow is affected. So absolutely, yes. The point is that the heart, so the circulation of the perfusion of a heart is more resistant to hypoxia compared to the brain, and also the kidney. So the fact is that the brain is very sensible to hyperperfusion, much less than the heart and then the kidney. But from a hemodynamic way of reasoning, it's even more perhaps. Okay.
So if this is everything, first of all, I would like to thank you, Professor, for this nice lecture. I think we can all agree that it was quite beneficial for us. And people online, if you can stay for us for extra 5 minutes, we need to do something small. But for now, I think we're done. Thank you so much, Professor, and we're looking forward for future collaborations.
Good luck to you guys. Thank you.